friends. Today we are going to discuss about some of the multiple choice questions that have appeared in the previous examinations. So now coming to NEET PG 2022 questions. A patient presented in the emergency department with symptoms of respiratory depression. So, he's breathing with lot of effort, or maybe you don't see respiratory effort, okay? And there is suspicion of overdose of opioids, maybe he's injected heroin, okay, or consumed a lot of codeine, okay, or maybe he has used other synthetic opioids like fentanyl, which is very risky, even a small quantity can cause respiratory depression. You must have heard about heroin getting contaminated with synthetic opioids like fentanyl, right? So this person has come with respiratory depression. He's really struggling to breathe, right? Or maybe you don't see his body moving, no respiratory effort. So what is the next step in management? Of course, you have to use a opioid antagonist, right? Because you need a drug to go and sit on all possible opioid receptors and reverse the effects of the opioid that he has taken, right? So you need a non-selective opioid antagonist, which is, it just has to go and sit on the opioid receptors. So such a non-selective, competitive opioid antagonist would be which one? The answer is naloxone. And naloxone would work either through IV, IM or as a nasal spray. You cannot give it as a tablet, okay? And it works very quickly within few minutes if you give IV or IM, okay? So it comes as a preloaded syringe, naloxone. So naloxone is the right answer. Buprenorphine is a partial agonist. Methadone is opioid agonist. These are used in opioid substitution therapy, OST, correct? For relapse prevention, you can use these drugs for OST. Naltrexone is a opioid antagonist, okay? But it cannot work so rapidly like naloxone, and naltrexone is usually a oral formulation, right? In a person who is in respiratory depression, you cannot think of giving a oral tablet, right? So naloxone preloaded syringe is used in this patient. So the answer is A. A patient consumed a large number of TCA. What is TCA? Tricyclic antidepressants. So can you think of one tricyclic antidepressant? Amitriptyline, right? Amitriptyline, which is frequently used. Other ones like imipramine, right? Dosulipin, nortriptyline. All these are tricyclic antidepressants. These are older antidepressants. So he has consumed a large amount of TCA pills and has presented with altered sensorium, hypotension, and ECG is showing wide QRS complexes. So, the ECG is showing widened QRS complexes, okay? So what is the next best step in the treatment? So the answer here is sodium bicarbonate, NaHCO3. You have to use sodium bicarbonate to reverse the cardiac toxicity. What is the risk of TCA overdose? It is cardiac toxicity, because TCA affects the sodium channels in your myocardial cells, okay? And it can cause bradycardia, signs of heart block, okay? Bundle block like features, bradycardia, and it can be reversed with sodium bicarbonate. So the answer here is C. After 5 days of normal vaginal delivery, a woman is brought to casualty by her husband. He reported that she has been crying all night. There is history of loss of appetite, difficulty in sleeping and feeling low. General physical examination is unremarkable. There are no significant findings on the pelvic examination, no other complications. Which is the best term to describe her condition? So this woman has come in the first week after delivery, okay, and has developed certain depressive symptoms. She's crying all night, lost appetite, insomnia is there, feeling low, sad mood is there. So if there are 3 or 4 depressive symptoms in a woman who comes in the first 1 or 2 weeks of pregnancy, right? And if this woman is not having, say, suicidal ideations, okay, this particular patient does not have suicidal ideation. She is also not having any, psychotic symptoms. Okay, there are no psychotic symptoms in this patient, correct? So, and especially if the person comes within 1 or 2 weeks of their delivery and there are no suicidal ideations, no psychotic symptoms, then the diagnosis would be postpartum blues. Postpartum blues can happen in up to 40% of women after delivery. So it's a very frequent thing, set of symptoms that we see in women who have delivered. Okay, and why that happens, why postpartum blues happens, is because of the hormonal changes. There is a dip in estrogen. So the dip in estrogen means there is increased levels of monoamine oxidase. Monoamine oxidase is the enzyme which is a digestive enzyme for your catecholamines like serotonin, norepinephrine, dopamine, right? So research has shown that monoamine oxidase level increases after pregnancy. The neurotransmitters like serotonin and dopamine reduce, which leads to these postpartum blues, right? So the answer here is postpartum blues. If the patient had suicidal ideation, psychotic symptoms, then you could have thought of postpartum depression or postpartum psychosis, right? So, which is not okay here. Next question, a 16-year-old adolescent female was referred for irresistible urge to eat, followed by episodes of self-induced vomiting. So, the person has an irresistible craving to eat, and then the person is feeling very guilty and probably is fearful that they are going to gain a lot of weight if they eat like this, and they are inducing vomiting, they are purging out. Okay, so the patient is also on appetite suppressants. So she's trying really hard to ensure that she does not develop a craving for eating food, right? So what is the most likely diagnosis? Is it binge eating disorder? In binge eating disorder, the person would eat heavily in binges, in short bursts, okay, and maybe develops a lot of guilt after that. That's binge eating disorder. What is pica? Pica is eating inedible stuff like paint, chalk piece, that is pica. What is anorexia nervosa? An individual starves themselves. They are restricting calories and food, okay. Despite becoming cachectic, they think that they are getting fat and they restrict food at all costs. So the answer here is bulimia nervosa, where there is an irresistible craving to eat food. The individual would have a normal weight, okay, that is another thing. Unlike anorexia nervosa, where the individual would lose lot of weight and become cachectic, okay, right? So in anorexia nervosa, they would develop cachexia, right? Whereas in bulimia nervosa, they would maintain normal weight. Now coming to NEET PG 2023 questions. A 25-year-old female patient is brought with symptoms of anxiety, palpitation, sweating, breathlessness, chest pain, feeling she might have a heart attack, feeling of impending doom. She may die, Patient had 5 to 6 episodes in a month, 30 minutes each since 6 months. What is the likely diagnosis? So very clearly, this person is having intense bursts of anxiety with lot of physical symptoms and a sense of impending doom. So the diagnosis here is panic disorder, right? It is definitely not generalized anxiety disorder. It is not agoraphobia. GAD is where there is free-floating anxiety, worries, and they don't have episodic anxiety like in panic disorder. Agoraphobia is fear of closed spaces or open spaces. Depression, very well, is about, low mood, lack of energy, lack of interest, right? So the diagnosis here is panic disorder. A chronic alcoholic with symptoms of confusion, ataxia, abducent nerve palsy, lateral rectus palsy, correct? Lateral rectus palsy and nystagmus is brought to the emergency. What is the likely diagnosis? So this person is a chronic alcoholic, so is probably, abusing alcohol or he is dependent on alcohol, right? And has developed altered sensorium, confusion, ataxia, unsteady gait, and also lateral rectus palsy, okay? So it has developed ophthalmoplegia, correct? Ophthalmoplegia, okay? So there is confusion, global confusion, okay? Global confusion, ophthalmoplegia, due to here lateral rectus palsy or other extraocular muscle palsy, and then there is ataxia or unsteady gait and nystagmus in addition. So the mnemonic to remember here is Goa, G-O-A, okay. You go to Goa and drink a lot of alcohol, right? You may end up developing Wernicke's encephalopathy, right? So the answer here is Wernicke's encephalopathy, which has these set of symptoms: global confusion, that is the person is disoriented, unable to recognize where he is, has difficulty remembering things, right? And ophthalmoplegia, or he has some abnormalities in the gaze, or may have nystagmus as part of ophthalmoplegia, and may have unsteady gait, ataxia. So remember the mnemonic Goa. So some people may ask, is it Korsakoff syndrome? Korsakoff syndrome is a consequence of Wernicke's encephalopathy. Here what happens is, it's a long-term complication. If an individual develops Wernicke's encephalopathy, they may develop amnestic syndrome, a chronic amnestic syndrome, where they have difficulty remembering, and specifically they have problem in new learning ability. So all of you have seen the movie Ghazni, right? So whatever happens just this day or just in these few hours, he has no recollection, but he remembers very well what has happened say a few years before or a few months before. So these individuals will not be able to make new memories. So it's something like a Ghazni syndrome, you can remember, okay? So new learning ability is impacted in Korsakoff syndrome. Such an amnestic syndrome is a consequence of Wernicke's encephalopathy. If you don't treat Wernicke's encephalopathy, they may develop Korsakoff syndrome. You know what is delirium tremens? We already discussed in the previous slides. De Clerambault syndrome is, not related to these set of symptoms, okay, right? So De Clerambault syndrome is associated with delusions that a particular, your partner is cheating on you, right? So the answer here is Wernicke's encephalopathy. A male patient comes with history of marital conflicts and complaints of early ejaculation, okay? So something called as premature ejaculation, okay? So not able to perform during sex for a satisfactory duration of time, right? Which of the following non-pharmacological, they don't want a drug here, the patient is asking, I'm not going to take any medication for this, I want a non-pharmacological method to treat my condition. So is it cognitive behavior therapy for premature ejaculation? May not be the most suitable idea here, okay, because you want the person to have immediate response. Exposure and response prevention is the gold standard treatment for OCD, obsessive compulsive disorder, right? Where you expose to the anxiety provoking stimulus. So if the individual is worried about dirt and contamination, you make the person touch a contaminated object, and then he should not indulge in compulsion of hand washing, right? He has to tolerate that distress and anxiety that arises. That is exposure and response prevention. You do it in a hierarchical fashion by choosing something which causes the least amount of distress, and you go on building the amount of distress slowly. That is ERP. So the answer is not ERP here. Is it sensate focused technique? Sensate focused technique is a very important form of sex therapy, okay? Here there are a certain set of steps which are used to teach individuals how to have a satisfactory sex life, if especially they they are not attracted to their partner anymore, or they are not able to perform sex anymore, right? And usually if these problems are psychogenic in nature, so they have gone to the urologist, they have got all the tests done, there is no problem in the nervous system, there is no diabetes, no hypertension, still they are not able to perform, right, in the bed, then probably sensate focus therapy is a form of sex therapy which can be useful. In our patient who has early ejaculation, one easy technique which can be used is squeeze technique, where you press just behind the glans penis as soon as you have a feeling that you may ejaculate or you may climax, right? Just holding behind, glans penis, either yourself or your partner holds it, so that it just delays it reduces that feeling of climax and you don't ejaculate immediately. So that is squeeze technique. So just teaching this squeeze technique would be quite useful for this particular patient. A patient with a diagnosis of schizophrenia not responding to haloperidol and thyroidazine, okay. So basically they have tried these typical antipsychotics, older generation antipsychotics, he is not responded to that. So he started on some drug, okay, drug A, which has side effects of siluria. There is a lot of salivation that this patient has developed as an adverse effect. This person also has developed dyslipidemia. So there is abnormalities in the lipid profile, also abnormalities in the blood sugars, okay, hyperglycemia. So what is the drug which is started here, right? Is it risperidone? Risperidone can definitely cause dyslipidemia and hyperglycemia. Patients can complain of some excessive salivation, okay, but it's not very characteristic. Aripiprazole and ziprasidone have lesser chances of causing these adverse effects, especially the metabolic adverse effects that you see with other atypical antipsychotics. So the answer here is clozapine. You know clozapine is the gold standard treatment in treatment-resistant schizophrenia, TRS, treatment-resistant schizophrenia. And the problem, you know, with clozapine, which is a very good drug in treatment of treatment-resistant schizophrenia, is that it causes lot of metabolic issues such as dyslipidemia, hyperglycemia, and also patients complain of increased salivation, okay. And you also need to monitor their blood, okay. You need to do a complete blood count every week, okay. For the first 3 to 6 months, you need to do CBC, right, complete blood count, just to ensure that the person doesn't develop agranulocytosis or neutropenia, right. Agranulocytosis is a severe problem that one can see in the usage of clozapine. It's an adverse effect which you need to monitor, correct? In addition, all these other problems can also be seen. So the answer is clozapine here. Thank you.